the role of the health center. So just a little bit of housekeeping within the GoToWebinar platform. You all are likely very familiar with this already, but just in case you're not, you should see either on the left or the right side of your screen a control panel, and in that control panel, you will have the opportunity to mute yourself, and then also you have the opportunity to provide any questions that you might have by putting that in the questions field or the chat box on the bottom, and we'll get to those questions at the end of both Grace and Elizabeth's talks. So just to give you a little bit of background about APCHO. APCHO is a national not-for-profit association of 35 community-based healthcare organizations, 29 of which are federally qualified health centers. Our members are dedicated to promoting advocacy, collaboration, and leadership to improve the health status and access of medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders in the U.S., its territories, and its freely associated states. So to dive right in today, we're going to have two speakers present to you all. First, they're going to actually do kind of a popcorn approach today, but we're going to have first Elizabeth Toxtis, who is the Public Policy Director of the National Viral Hepatitis Roundtable, speak, and then Dr. Grace Wong, who is a family physician at International Community Health Services, which is based in Seattle, Washington. And just to quickly introduce myself, I am the Director of Policy and Advocacy at APCHO, and my name is Isha Weerasinghe. So a quick outline of how the webinar is going to go today. We're going to go over how the NASEM report was developed, that there were two phases. Then we're going to talk about what health centers can do and highlight some of the key recommendations that are relevant to health centers. And then we're going to go into a Q&A. And I highly encourage you all, if you have some of these practices and strategies that you've been using or will continue to use or enhance within your health center, to share those during the last part of this webinar. So with that, I'm going to pass it on to Elizabeth.
Okay, thanks, Isha. So the National Academy's report, there were two phases. Just so you know, the National Academy's, it's a private nonprofit institution, provides independent, objective analysis and advice to the nation to solve complex problems and inform public policy decisions related to science, technology, and medicine. They operate under an 1863 congressional charter signed by President Abraham Lincoln, and it used to be known as the Institute of Medicine. In 2015, they changed their name to the National Academies. Next slide. So there are two phases to this report. The first one was released in April of 2016. The phase one report asked the question of whether it was feasible to eliminate hepatitis B and C from the United States. And their conclusion was that it was feasible, but that, they still needed to devise a strategy for how that was going to happen. And that's how the phase two, that's what the phase two report addressed, is what the strategy would be to eliminate viral hepatitis. So that's the phase two report is the one that was just recently released in March of 2017. And there were a variety of sponsors. I guess next slide, we can look at the sponsors. So we had, it was a collaborative effort with some involvement from community, AASLD, CDC, divisions of viral hepatitis and cancer prevention and control, IDSA, my organization, MVHR, and the Department of Health and Human Services Office of Minority Health. So next slide. This is just, obviously, we're zeroing in on the phase 2 report. So that's what we're going to review in this webinar. So next slide.
Thanks, Elizabeth and Isha. So the report recommendations that we will look at, we'll start with ways in which health centers can be involved. And 3 areas that you see listed here are, 1, looking at the populations that we serve and being really on top of that data, because that's really going to be important. The prevention and treatment services we provide, and the partnerships that we have to provide these services. Okay. So the first thing that we're going to be discussing is population data, but I did want to give a little bit of background because I think it's important for us to recognize that the effort that is going on in the United States is actually part of an international effort. And as part of the report, there were models commissioned that incorporated the World Health Organization's targets for the international hepatitis elimination effort. And here you see in bold the WHO targets for diagnosis and treatment. And for hepatitis B, were we actually able to diagnose 90% of everyone who does have the condition and have 90% in care and 80% with treatment, we could really make a difference with the 50% reduction in mortality, a decrease in new hepatitis B-related hepatocellular carcinoma by 1/3, and a decrease in new hepatitis B-related cirrhosis by 45%. Next slide. Similarly, for hepatitis C, if there was treatment without restrictions and we were able to diagnose new infections, even as prevalence decreases, there would be a 65% reduction in mortality and a 90% reduction in incidence. And on the bottom are just sort of the goals that we would need to meet for the number of new infections diagnosed in order to meet these targets. Next slide, please. So here are some of the recommendations related to public health information. And just as an aside, when we go through the recommendations from the report, you'll probably notice that the federally qualified health centers aren't ever mentioned as a specific party responsible, but I would like you to pay attention to the content of the recommendation because there are many things that we can do. You'll also note that I've taken some license in bolding certain areas of recommendations that are important to pay attention to, just so that you know when you read the recommendation itself as it's published, it doesn't have the areas that I've put in bold, and that's just poetic license that I've taken. So the first recommendation related to public health information has to do with the CDC in partnership with state and local health departments, support standard hepatitis case finding measures, and the follow-up monitoring and linkage to care of all viral hepatitis cases reported through public health surveillance. The CDC should work with the National Cancer Institute to attach viral etiology to reports of liver cancer in its periodic national reports on cancer. And the second part of this recommendation is extremely important because I think if we look at our cancer data, we can see that while there have been sizable improvements made and decreases in the incidence of breast, lung, prostate, and colon cancer, hepatocellular carcinoma is increasing. The second recommendation has to do with public health information is that the CDC should support cross-sectional and cohort studies to measure hepatitis B and hepatitis C infection incidence and prevalence in high-risk populations. Next slide. There's also a recommendation related to population data that says that the CDC should work with states to identify settings appropriate for enhanced viral hepatitis testing based on expected prevalence. So an example of this would be things like perhaps one-time testing in emergency rooms, where there have been studies published that show that the prevalence of hepatitis C is 3%, even among those who would otherwise not be targeted by current screening recommendations. Next slide. And on this slide, you'll see the current United States Preventive Services Task Force screening recommendations for hepatitis B and hepatitis C. And just to remind us all that when it's a grade B, it means that there's high certainty that either the net benefit is moderate, or there's moderate certainty that the net benefit is moderate to substantial. And the recommendation is to offer or provide this service. Next slide. So while we don't have time to review in detail the screening recommendations that were on the previous slide, I don't want to overlook the fact that it is very challenging to do that, particularly when the risk factors for screening might be things that we don't ordinarily collect, ordinarily have access to. And so I just want to acquaint you with some efforts that have been successful in identifying ways to do this, and is information that hopefully some of you on the call can take advantage of. This is an effort that was funded by the National Institutes of Health. It was a project in conjunction with the health center that I worked at and the organization that's putting on this webinar, APCHO, and you see the primary investigators listed. Next slide. This is an extremely busy slide, but just to show you that part of the effort for this project was to develop an algorithm using electronic health record data to be able to identify who should be screened for hepatitis B, which again can be challenging because the risk factors have to do with country of origin, and that can sometimes be difficult to get at, and this was a method that used language as a surrogate. Next slide. So what else should health centers do? We've talked about population data. We'll talk about partnerships and treatment later. So we're now going to talk about prevention services, and in this category, we'll talk about medication-assisted treatment, immunizations, and Elizabeth will talk about some advocacy efforts. Next slide. So these are the recommendations in the report that talk about prevention services, and one has to do with access to adult hepatitis B vaccine and removing barriers to free immunization in pharmacies and other accessible settings. And then the second recommendation has to do with having states and federal agencies expand access to syringe exchange and opiate agonist therapy in accessible venues. And I think with respect to immunizations, it's important to note that only 25% of adults who should be getting hepatitis B vaccine are getting hepatitis B vaccine. And we know we can do that better in this country when we look at other vaccines like the flu, or which is, I think, in the adult population is 40% and actually higher if you're over the age of 65. And so I show you this resource that, as someone who's worked in a community health center for several years, has used quite often, and this is the Immunization Action Coalition. They have wonderful resources. Things you might want to look at in your own health center are what are the workflows and processes by which your patients get adult hepatitis B vaccine. And I would urge you to look at how your center can use these tools to be part of the elimination effort. Next slide. For medication-assisted therapy, I would strongly urge those of you who aren't already doing this to seriously consider implementing these types of programs at your health centers. We know that there's great disparity in the United States on access to medication-assisted therapy and syringe exchange. If you were to map it out, you would see that most of the providers who have the waiver to prescribe things like buprenorphine are mostly on the coast, and that in rural and middle America, access is extremely challenging. Those of us who've been fortunate already to be the recipients of Bureau of Primary Healthcare dollars to support the implementation of their services have benefited from the information that you see available through SAMHSA. For those of you who aren't providing this service yet, I believe that at the most recent HRSA All Program webcast, which took place at the end of May, that we heard that there are actually going to be more grant dollars available to do this. So I would urge you all to do this. Next.
So once again, the recommendation 4-3 states that, urges state and federal agencies to expand access to syringe exchange and opioid agonist therapy. In terms of getting involved, in state advocacy around this recommendation, I think that it's important to find out if syringe exchange programs are legal in your state. As the report says, that the syringe exchange programs are proven to reduce the risk of hepatitis transmission, but they're illegal in some states. So AMFAR has recently put out, they've sort of launched this website that tracks, what's legal, what's not legal in terms of medication-assisted treatment and syringe exchange programs. And I think that's a really good resource for anyone who's interested in getting involved in advocating for the legalization of these programs. It's opioid.amfar.org, as you can see there. And if you find out that they are illegal in your state, then it's probably best to contact your state legislators and your governor, because it's state by state. These are state determined laws, not federal, federally determined, so to speak. So it's best to contact the elected officials in your state and demand that these programs be legalized based on everything that the National Academies laid out in their report. Next slide.
So we've covered population data. We've covered prevention services. Click, please. Click. So now we're going to talk about partnerships and treatment, and the areas we'll look at are primary care, criminal justice, and advocacy. Next slide. So here are recommendations that I think relate specifically to primary care. The first one is related to OB care, and it says that the CDC, our colleagues in the study of liver diseases and infectious disease specialists, as well as our colleagues in OBGYN, should recommend that all hepatitis B surface antigen positive pregnant women have early prenatal hepatitis B DNA and liver enzyme tests to evaluate whether antiviral therapy is indicated for prophylaxis to eliminate mother-to-child transmission or for treatment of chronic active hepatitis. And then there's also a recommendation that says that our colleagues who study liver diseases, our hepatology colleagues, as well as our infectious disease colleagues, should partner with us in primary care and our professional organizations to build capacity to treat hepatitis B and C in primary care and these programs should set up referral systems for medically complex patients. So again, for those of you that do OB, make sure that your protocols and practices follow recommendation 4.2. And all of us who are doing primary care at health centers certainly have the ability to follow recommendation 5.2 with a variety of partnerships and methods. Next slide. So one example that I think most of us know about is something called Project ECHO, and ECHO stands for Extension for Community Health Care Outcomes. And this model has been used extensively in the United States and internationally for a variety of conditions using teleconferencing technology. We know that there's much evidence for using this method with the successful treatment of patients with hepatitis C. And the great news is that at this present time, there's actually a tele-ECHO effort available to HRSA grantees on reducing hepatitis B perinatal transmission. Next slide. Next. There's also a recommendation on the criminal justice system that both Elizabeth and I will be speaking to, and it reads that the criminal justice system should screen, vaccinate, and treat hepatitis B and C in correctional facilities according to national clinical practice guidelines. And the report called out the importance of attention to this population, which has been shown to have up to 35% of those in the criminal justice system have hepatitis C, and close to 4% have hepatitis C. Next slide. So one way that health centers can certainly have a role in hepatitis B and hepatitis C elimination efforts in partnership with the criminal justice system is to provide continuity of care after release. And this is a screenshot of a website for the Community-Oriented Correctional Health Services, which is an organization that can help health centers who are interested in pursuing these types of partnerships and services.
So just a little background on the criminal justice recommendation. So about 90% of prisoners in this country are incarcerated in state prisons as opposed to federal prisons. And it's estimated that about a fifth of the people housed in state prisons have hepatitis C. And since many states many state prisons do not perform opt-out testing, the chances are that the infection rates are higher than that estimate. So the question is, of course, why does it make sense to screen and treat people in state prisons other than for the reason that the infection rates are so high? And there are a few different ways of looking at this. There's the public health answer, which is, when somebody is re-entering society after being incarcerated, if they've already been treated or vaccinated, they won't be spreading the virus. So it helps the community at large. You've got at least 10 million people cycling in and out of prisons and jails, huge population, and more than 90% of those convicted are released within a few years. So again, it's a chance to treat people in a confined setting, and that's going to make a big difference for when they are released back into the community. And there's also the legal answer to that question, which is that state prisons can be on the hook if they don't treat people. There's, Supreme Court precedent that it may constitute an Eighth Amendment violation if state correctional agencies display deliberate indifference to the serious medical needs of prisoners, which includes the need to be treated for viral hepatitis. And there have been recent federal court rulings in our favor in terms of showing that that's an Eighth Amendment violation. Moral answer is pretty clear. I just put that there as a reminder. It's not just about these, sort of abstract, reasons, but as we know, we sort of have a moral obligation to treat people regardless of whether they're incarcerated or not. Next slide. So it's tough to come up with ways to engage in terms of state advocacy on this issue, because state prisons really have few options for obtaining drug discounts or discounts on hepatitis C medications, which of course are very expensive. And many state prisons are not going to want to test or screen prisoners if they can't afford to treat them. So the question becomes how to get affordable prices for the state prisons. And there are all kinds of strategies being floated, and I know, like, on behalf of MVHR, I'm working with some of our partners in terms of coming up with ideas for making changes to federal policy to address this issue. But in terms of state advocacy, I think that it would make sense to contact, your governors and state legislators and ask that more money be appropriated, specifically for departments of corrections to treat people with HCV. It's not an unreasonable request, and it may push them to start, putting pressure on the federal government to help them out here with some options in terms of giving them power to negotiate for lower prices. So next slide.
So the remaining recommendations we'll quickly go through, so you all have a chance to ask some questions, but they have to do with oversight and coordination, monitoring compliance, and access to medication. Next slide. Next slide. So the report recommendations have to do with oversight and coordination. One is that the highest level of the federal government oversee a coordinated effort to manage viral hepatitis elimination, much as similar to what's been done for HIV. And similarly, the second recommendation is that the Department of Health and Human Services should work with states to build a comprehensive system of care and support for special populations with hepatitis B and C on the scale of the Ryan-White system. Next slide. With respect to monitoring compliance, there's a recommendation that NCQA should establish measures to monitor compliance with viral hepatitis screening guidelines and hepatitis B vaccine birth dose coverage, and include the new measures in HEDIS. Next slide.
So a couple of final recommendations to look over relate to access to medication, treatment access. So recommendation 4-5 urges public and private health plans to remove restrictions that are not medically indicated and offer direct-acting antivirals to all chronic Hep C patients. And 6-1 is urging the federal government to purchase the rights to a DAA for use in neglected market segments, which means Medicaid, the Indian Health Service, and prisons, state prisons, like we talked about. And they recommend it as a voluntary transaction. They're not, recommending that the federal government invoke its power to sort of just provide reasonable compensation to a pharma company and then just take the rights to that drug. They're actually just, it's sort of like nudging the pharma company toward exploring this idea. Next slide. And I'll just talk a little bit about advocacy in terms of the first recommendation, 4-5. So they're referring, right, the national academies to the treatment restrictions imposed by the private health insurers and Medicaid. And although many private health insurers have loosened their restrictions, many state Medicaid programs have not. There are 3 main restrictions imposed. The number one, fibrosis criteria. So basically, Medicaid wants to limit treatment to people who have more advanced disease. To involve sobriety requirements. Some programs will impose the requirement that someone be abstinent from drugs or alcohol for a period of time, 3 months up to a year sometimes. The third one relates to prescriber limitations. It's, some programs will say, well, you're not going to get the drug unless the prescription is written by a specialist. So these are just hurdles, to make, to make it more difficult for people to get the drug. So Medicaid can say they, because they don't want to pay as much. But I guess in terms of state advocacy, it's, the first thing to do would be to find out if your state's Medicaid program imposes any of these restrictions, and contact your state's Medicaid director and voice your concerns. NVHR put out a preliminary report last October reporting on treatment access for people who are enrolled in Medicaid, and found that many of these restrictions still exist. What we're going to be putting out hopefully in September is our final report on the state of Medicaid access for hepatitis C patients, and we'll be grading all of the states based on the restrictions that they still have in place. So that's something to look out for this fall. And next slide.
Okay, thank you, Elizabeth, and thank you, Grace. So we're on to the Q&A portion of the webinar. We have about 20 minutes to be able to talk about any questions that you might have, or strategies and techniques that you all want to share for the rest of the group that you've been using. So I don't see any questions so far, so I'm gonna go ahead and lead off by asking, this question's for you, Grace. So now that this report has been developed, I know Elizabeth was talking about some of the process, and we know that we've had a number of federal reports developed in the past. How do you think that this particular report and the 2 phases are going to help health centers?
So I think the reports themselves have a lot of good information about the state of care for folks with hepatitis in this country, as well as the many challenges that we face both with identifying and engaging the people who need it in treatment. I would say that these reports provide tools for health centers to advocate on behalf of their patients, as well as reminders for practices such as some of the ones that we discussed in this webinar, to make sure that we're all doing the best we can around things like, are we identifying everybody who should be tested? And then are we making sure that in the case of hepatitis B, people who are at risk but who aren't infected are getting immunized? And then for both hepatitis B and C, are we making sure that they are getting the appropriate management and treatment and follow-up?
Thank you. The next question, we received one question that asks about why hepatitis screening isn't a standard part of treatment protocol in opioid recovery programs nationally? That question's for either of you.
Well, I think, just from a policy standpoint, I mean, that's something that advocates need to be asking their elected officials. And as advocates, we should be trying to emphasize the direct link between hepatitis and opioid abuse. Because I think there's recently a report came out showing that hepatitis is 9 times more prevalent among opioid users, or they're 9 times more likely to have it. So it should be started apart, and maybe that's just a lack of awareness, in terms of the public health community or the people who are running these recovery programs. It's also one thing I should have mentioned before too, in terms of these programs that are so well funded by Medicaid. If you're looking for ways to get involved in advocacy, I would recommend any kind of efforts to oppose the effort to dismantle the Affordable Care Act, because the Republican bill, it would basically destroy Medicaid as we know it, and we would not have these recovery services to the extent that we do today. But I don't know, Grace, if you wanted to add anything.
So I would like to do an answer from the perspective of a primary care provider. And I think if you are looking at having opioid treatment services as part of primary care, then absolutely it is part of the standard of care, because if you look at the risk factors for the United States Preventive Services Task Force screening recommendations, injection drug use is listed for both hepatitis B and hepatitis C. So I think the question that's being asked is a very good one, and I think my short answer would be I think it's the context for where the services are being provided. If they are being provided in primary care, absolutely it is the standard of care.
Okay, thank you both. So the next question is just a clarification question. So the participant asked whether the recommendations say that it doesn't matter whether somebody is sober while they're taking medications for hepatitis. Elizabeth, you were talking about the opposite in terms of, yeah.
Right. So so the National Academies recommends that restriction be lifted. Yes. So some Medicaid programs and health insurance, health insurers will say, oh, you have to be sober while you're taking this medication. You have to prove it. You have to prove that you've been sober for a certain period of time or something like that. And the National Academy said, no, you should not be requiring that of people. People need to be treated. And, their, drug abuse or alcohol abuse is just another issue, and they should be treated for hepatitis regardless.
So just to review, the recommendation is that public and private plans should remove restrictions that are not medically indicated and offer direct-acting antivirals to all chronic hepatitis C patients. That's the wording in the recommendation.
I think that's another point as to why this report is so valuable. Okay, the next question is whether there are any possible legal actions for those who are withholding medications for Medicaid recipients if they have a low fibrosis score.
Absolutely. I mean, there are lawsuits going on there as we speak, and like I was saying before, that this has been considered an Eighth Amendment violation, at least in the context of prisoners. Sorry, my screen just went blank. But I mean, yeah, there have been cases litigated in Washington State, another state too, where the judge said, you know, Medicaid programs cannot do this. You have to cover what's medically necessary under the Social Security Act, that, you know, of which Medicaid is a part. So there's legal precedent for this. It's you know, really is illegal for them to withhold those meds on that basis. So the answer is yes.
And Elizabeth's a lawyer, so she knows. And next question also is for you, Elizabeth. So the report, the question asks, the report talks about state incarceration facilities, not for-profit incarceration facilities. So this person had mentioned that he agrees that treatment should occur on the inside prior to the release of the incarcerated into the public mainstream. We can contact our governor, but who do we contact for the for-profit organizations? How do we make sure that they are held accountable?
So I assume the for-profit organizations, meaning private prisons. I would still contact your governor, because basically the state makes a decision about whether or not they're going to contract out their prisons, right? So sometimes the state will run the prison itself, but sometimes the state, you know, basically the governor and the legislature will decide, we're going to contract this out to a private prison company like CCA, which I think that's still their name, Corrections Corporation of America. They may have changed it. Sometimes they try to change their name so that people will forget that they're the you know, horrible companies. But yeah, or GEO is another big private company. Basically, you would still want to contact your elected officials, because they're the decision makers in terms of, you know, who's going to be running their prison systems.
Thanks, Elizabeth. The next question is for Grace. At the beginning of the presentation, you had mentioned that your goal is to reduce hepatitis mortality by 50%, and you want to achieve this using the various percentages strategy. So how does a health center know their baseline for numbers of people in care?
So that's a great question. One is you want to make sure that everyone who should be tested is getting tested, and through that you will identify who already has the condition or who doesn't but is at risk and needs to be immunized. And then you would have the ability to do population management by making sure that everybody who should be immunized is getting immunized, and then everyone who should be managed, you're tracking over time to make sure that they're getting the appropriate care based on, in the case of hepatitis B, what their periodic blood and ultrasound testing shows. In the case of hepatitis C, hopefully you're in an environment where you're not being restricted in your ability to provide them the treatment that they get, and being able to monitor treatment completion and the follow-up for that. Does that answer the question?
Let us know in the chat box if that answers your question. The next question is one that we talk about a lot. The question asks, do you know the average lifetime cost of treating a case of chronic hepatitis B versus the cost of vaccination? So I could just start by saying that we've looked at this a lot in terms of cost effectiveness studies, but there aren't that many cost effectiveness studies looking at the lifetime cases, just because of the length of progression of disease, and there just haven't been a lot of studies based in the United States. But there is one study that I know of that looks at the cost of working on prevention versus intervening later on in the progression of chronic hepatitis B when a patient is closer to HCC or cirrhosis. So I can provide that in the follow-up materials, but I don't know if Grace or Elizabeth, you have any other responses to that.
Well, I think there's a very simple answer, which is to look at the cost of the vaccine, which is something in the hundreds, presumably, versus having to do ongoing testing over time. And, you know, you're talking about, for your average person, this probably goes on for decades. So if you just look at what are the costs of the testing that you have to do, that includes blood work and ultrasounds. And that's not even factoring the cost if you were developing some of the complications like cirrhosis or hepatocellular carcinoma. So not having exact numbers in front of me, I would still say that if you were to compare the cost of the vaccine with all the care that is needed if somebody is infected, it's still going to be a much better return on investment to do the vaccine if you could possibly do that and prevent the disease.
Thank you, Grace. Are there any other questions or comments that anybody might like to share? That was a good set of questions. And Grace, to your question before about whether you resolved that question about the baseline, the participant said that you had.
Thank you.
Okay, with that, if there are no more questions, we'll go ahead and end the webinar 6 minutes early and give you a little bit back, a few minutes back. And apologies again for the late start of the webinar. We hope that this was helpful for you all, and please reach out if you have any further questions, and we'll provide contact information and a recording of the webinar in our follow-up. Thanks so much.
Thank you.
Thank you.